Welcome to Southwestern Human Services Fraud, Waste, and Abuse Documentation and Utilization Training. The agenda for today is to review Southwestern Human Services policy for fraud, waste, and abuse, review the Quality Assurance Satisfaction Survey, review what fraud, waste, and abuse is, review the documentation, the utilization of services, and then questions and answers. Southwestern Human Services has established procedures to prevent and detect fraud, waste, and abuse that comply with the regulations set forth by the Office of Inspector General of the Department of Health and Human Services and with the requirements of the Bureau of Program Integrity of the Department of Public Welfare. Practices also comply with regulations established by Health Choices Managed Care organizations. Southwestern Human Services is committed to ongoing training of employees to educate and attempt to control fraud, waste, and abuse. In circumstances where fraud has been established, Southwestern will take all necessary actions required along with local, state, and/or federal agencies to address the actions of the perpetrator of fraud. All policies, procedures, and regulatory materials are available for review in the IBHS department. What is fraud? Fraud is the intentional deception or misrepresentation made by a person with the knowledge that the deception could result in some unauthorized benefit. This includes any act that constitutes fraud under applicable federal or state law, knowingly or intentionally submitting false claims. Some examples of fraud: to purposefully bill for services that were not provided, rounding up of time, willfully falsifying the content of any part of a progress note, encounter form, or treatment plan, the dates, times, place, type of service, persons present, or even the content of the note, forging a signature of the parent or guardian or caregiver, falsifying your credentials, billing for program material that the provider did not create, billing for the same program material for more than one client, overlapping services. For example, you billed a med check at the same time as a therapy session. Services not performed by the billing provider. The contracted and credentialed licensed practitioner has another licensed practitioner perform the services and bills for it. Using a signature stamp on progress notes. And lastly, falsifying the timesheets or theft of time. What is waste? Waste is thoughtless or careless expenditure, consumption, mismanagement, use, or squandering of healthcare resources, including incurring cost because of inefficient or ineffective practices, systems, or controls, the overutilization of services or other practices that result in unnecessary costs. Examples of waste: being inefficient in the methods of how treatment is delivered, inadequate collaboration, submitting incomplete and/or inaccurate paperwork, using interventions that are proven to be ineffective, failure to establish target dates for completion, failure to organize treatment to achieve expected outcomes, providing services at a subclinical level, and lastly, misuse of resources. What is abuse? Provider practices that are inconsistent with sound fiscal, business, or medical practices and result in an unnecessary cost to the Medicaid program, or in reimbursement for services that are not medically necessary or that fail to meet professionally recognized standards for healthcare. It also includes recipient practices that result in unnecessary costs to the Medicaid program. Some examples of abuse are billing for non-covered services, billing services by mistake, attempting to obtain services where medical necessity has not been established, poor utilization of services while attempting to extend services, using the services to supplant the parent caregiver's responsibilities, misusing staff's time, and creating any unnecessary overtime. The history of program integrity. The Federal False Claims Act. They are liable for a civil penalty of not less than $5,000 and no more than $10,000, plus 3 times amount of damages for those who submit or cause another to submit false claims. There's the False Claims Whistleblower Employee Protection, the Stark Law Social Security Act of 1877, the HIPAA 45 CFR Title II, 201 through 250, and lastly, the Administrative Remedies for False Claims and Statements, 31 U.S.C. Chapter 8, 3801. Some regulatory changes have been the Fraud Enforcement and Recovery Act of 2009. This amends the FCA's intent requirement. A false statement need only to be material to a false claim. FCA now prohibits knowingly submitting a claim for payment known to be false or fraudulent, making or using a false record material to a false claim or to an obligation to pay money to the government, engaging in a conspiracy to defraud by the improper submission of a false claim, or concealing, improperly avoiding, or decreasing an obligation to pay money to the government. The Patient Protection and Affordable Care Act expands audits and government programs and requires providers to return any overpayment within 60 days of identification. It increases sentencing guidelines for healthcare fraud, makes obstructing a fraud investigation a crime, and makes it easier for the government to recapture funds. It enhances provider screening and enrollment requirements. It increases funding to prevent, identify, and fight fraud by $350 million over the next 10 years. All providers will be audited. You are a provider. Current audit activities. The Bureau of Program Integrity was created to ensure, among other things, that the Pennsylvania Medical Assistance Program is protected from provider fraud, abuse, and waste, and that MA recipients receive quality medical services. BPI audits can be conducted at random or based on complaints, referrals, and tips. All providers are at risk. BPI will review records, conduct interviews, and make on-site visits to determine if services violate MA regulations. Serious sanctions can be imposed upon providers who fail to meet state and federal regulatory guidelines. A compliance audit is a comprehensive review of an organization's adherence to contractual and regulatory guidelines to evaluate the strength and thoroughness of its compliance preparations. Auditors review policies and procedures, internal controls, and risk management procedures over the course of an audit. A program integrity audit is a comprehensive review of an organization's adherence to contractual and regulatory guidelines to evaluate the strength and thoroughness of its efforts to prevent, detect, and correct fraud, waste, and abuse. A claims billing audit is a review of medical records and other relevant documents to determine whether the documentation supports payment of a claim for services. Federal level activities. The Medicaid Integrity Group is responsible for implementing the MIP. Medicaid Integrity Contractors are the regional contractors hired through the MIP to ensure paid claims were 1, properly documented, and 2, billed properly using correct and appropriate codes for covered services and paid according to federal and state laws, regulations, and policies. Consequences of fraud, waste, and abuse. If fraud is confirmed, immediate termination and legal action, including criminal prosecution by the Pennsylvania Office of the Inspector General. Under the Federal False Claims Act, if a person knowingly submits a false claim and knowingly makes a false record or statement to have a false claim paid by a federally funded healthcare program, that person is subject to civil penalties. The person is liable for up to triple damages and penalties between $5,500 and $11,000 for each false claim that is knowingly submitted. In addition to civil penalties, individuals can also be excluded from participating in any federal health care program for non-compliance. Recognizing fraud, waste, and abuse. Common fraudulent activities are billing for services not provided. For example, billing for time when the member is not present, extending session, and having parents sign when you did not provide the service. Using false credentials, for example, signing off as having certification when the credentials expired or were revoked. Double billing, getting paid the maximum allowable amount for the same service by 2 different funders. Billing for phantom patients, billing for members that do not exist. Co-payment evasion, failing to tell the provider about other health insurance. Providing false information or misrepresenting income. Sharing or theft of medical benefits, or member sharing an ID in order to receive treatment. Recognizing fraud, waste, and abuse activities continued. misrepresenting the diagnosis to justify the service, or exaggerating symptoms to obtain more services, misrepresenting the type or place of service, or who rendered the service, stating that the service was performed in the home when it was actually provided at the member's school, billing for non-covered services, for example, billing or printing information off of the internet, inappropriate documentation for services billed, for example, clinical documentation fails to support the service provided. Upcoding, which is billing for outpatient individual services instead of outpatient group services, the service that was actually performed, in order to obtain more money. Recognizing fraud, waste, and abuse activities. Delays in discharge. For example, continuing to provide services when member no longer meets medical necessity. Duplicate documentation for separately billed services. For example, the same note is copied for the same member or for different members. Forgery. Failure to collect coinsurance deductibles. Failure to resolve overpayments or kickbacks, which is making arrangements with the referral source and paying the referral source to send members to your facility. Recognizing fraud, waste, and abuse activities continued. Unexplained, entries of altered records, unauthorized transitions, missing signatures, discrepancies in handwriting, lack of or out-of-date written policies and procedures, including those safeguarding assets, missing files, reports, data, and invoices, both electronic and paper, missing weak or inadequate controls, and inadequate monitoring by management. If it's not documented, it didn't happen. Basic documentation requirements. All staff are required to know SHS's documentation, policies, and procedures. Critical issues include start and stop times, service codes, individualized progress notes. Notes must be specific to the member, appropriately support the time, type, etc. of services billed, and tie back to the individualized treatment plan. The member's name must be included on all notes. Basic documentation requirements. The units billed. The units billed must match the number of units on the documentation. full signature with credentials and dates, covered versus non-covered services. Are the services that are documented actually covered services? Service definitions, the services provided / documented must meet the service definition for the code billed. Basic documentation requirements. All documentation billed for must be available for review in Members Chart. Documentation must include all required elements, DAP format for BCMT, measurable objectives, place of service, persons present, etc. Provider signatures must be present. Services must be provided according to requirements. The progress note must indicate the progress at each visit, change in treatment, and response to treatment. It must include the relationship of the services to the ITP. It must state the specific intervention that was provided to the member. And it also must indicate the plan for follow-up. Lastly, progress notes that consist of mere observations do not meet regulatory requirements. Therefore, those sessions would not be considered reimbursable sessions. CCBHO Auditing Checklist. Missing documentation, billed for services not rendered, documentation supports fewer units than billed units, overlapping services, billing for non-billable services, no breaks in time from one venue or member to another, and documentation does not support the submitted claim. The auditing checklist also includes no treatment plans present in the records, billing for travel time when prohibited, signature stamp on progress notes, no consent for treatment, individualized treatment plans that are not signed by the member or the parent, identical, nearly identical treatment plans, and also identical and nearly identical progress notes. Lastly, the correct times, AM and PM, must be included. Some utilization issues that occur is that parents do not understand IBHS. Parents do not understand the ITPs. Parents do not understand their role within the service. Insufficient support or collaboration efforts. Barriers to treatment within the member, caretaker, provider, and environment. Contingency plans to address barriers are not in place. Cultural competency issues, and that the service fails to be flexible. Continued utilization issues. The service fails to be child-centered and family-focused. There are therapeutic boundary issues. Under prescription, therefore extended length of service for the plan periods. Frequent cancellations, dissatisfaction with services, no commitment to services. The member is enrolled in the wrong service. For example, it's either too intensive or not intensive enough. Dissatisfaction with staff, scheduling issues, and lastly, low confidence level in the service's ability to reach expected outcomes. What can you do? If you suspect fraud, waste, or abuse, you must contact your supervisor immediately. You can also contact the Fraud, Waste, and Abuse Hotline at 877-499-7295 or submit a formal complaint at www.opm.gov/our-inspector-general/hotline to report fraud, waste, or abuse. And lastly, be vigilant about the accuracy of your documentation and about the clinical processes that you utilize.